Good evening, everyone, and welcome to today's e-class. And so we have very uh, good people, experts in electrophysiology, and it's a very important topic which we all would like to know about and learn further. So Dr. Daljeet Kaur is the speaker for today. She would be speaking about ECGs and basics and basic EP tracings. Then we have very august faculty with us, Dr. Sharada, very renowned electrophysiologist and DM from AIMS Delhi. And all our other members of the WINCARs are already there. So, do we have already Dr. Mukund Prabhu here?
Yes, madam. Good
Yeah,
evening.
ma'am, he's there.
Yeah, good evening, Dr.
Good evening,
Mukund
madam.
Prabhu. So, welcome all of you. And let us start the presentation by Dr. Daljeet. Uh,
Sure, ma'am. Thank you very much, ma'am. Thank you for the introduction, ma'am. Thank you, Vincas, for having me here. So, my responsibility is to talk about ECGs and basics of EP tracings and understand that this is for our DMDNB cardiology students. So I'll be talking very basics about relation of the ECGs and with the basics of EP tracings, or in the electrophysiology lab, what are the basic recordings we do, and to some extent how do we differentiate these different kinds of tachycardias. I'll not go into the complicated ones, but the commonest ones which we see in the clinical practice, which is AVNRT, AVRT we talk, or atrial tachycardia, or for that matter, how do we know it's a VT or supraventricular tachycardia. I'll show some basic EP tracings. Plus, I'll be showing something, how do we do recordings? Because I know as an interventional cardiologist, usually, I'm not talking about the structural heart disease, but usually interventional cardiologist, we are working mainly in the coronary arteries, right? But here we are working inside the heart, and here we need to understand how is the right atrial or left atrial anatomy, or for that matter, coronary sinus or RV apex. So how do we place the catheters, and to some extent, what are the basic catheters we use in the electrophysiology laboratory. So I would start with the case example, a commonest case example of a young female presented with palpitations, having a structurally normal heart, having a regular narrow QRS tachycardia. So whenever we have a regular fast narrow QRS tachycardia, what we say in the teaching, we always say that first search for whether it's a narrow or wide, whether it's regular, irregular, and relation of the P wave to the QRS, or whether P's are more than QRS, or is there a fixed relation between P and QRS, right? So usually in this tracing, it's difficult to decipher the P waves. And one common thing or common mistake which happens when you have a narrow QRS regular tachycardia, if you can see, these are the big low amplitude waves, which we can confuse. We can discuss whether it's a P wave or T wave. But always remember, if there is a QRS, there will be a definitely T wave, right? If there is a depolarization, there should be a repolarization. Whether P is there or not, but if there is a QRS, T should be there. So always remember, when you have a QRS, after that there is a low frequency wave, definitely this is a T wave. And we need to search for the P wave here somewhere in the isoelectric segment or within the QRS. Just for our understanding, what I did, I highlighted lead V1. And I think we have read in a Brownell usually that you search for the P wave either on the ST segment or in the distal part of the QRS, or maybe within the QRS. And I think many of the students know that if there is a small blip or notch in the distal part of the QRS, which is not there in the baseline ECG, this is a short RP tachycardia. I'll talk about in detail what do you mean by short RP tachycardia. But yes, the P wave 1, it is in the distal part of QRS. Second, the P wave is very narrow. It's not very wide P wave, very narrow P wave. So when the P wave is very, very narrow, not forming a very nice big blip, that means it's coming from the central part of the heart, causing activation of the right and the left atrium almost simultaneously. Always remember this. So we will go to what do you mean in a layman's or common term? What do you mean by supraventricular tachycardia, or what do you mean by ventricular tachycardia? Any arrhythmia or fast heart rate which happens at or above the level of the His, it is supraventricular tachycardia. Forget it whether it's wide, narrow, whatever it is. But any arrhythmia which arises at the level of the His or above, maybe atrial myocardium, sinus node, AV nodal re-entry, accessory pathway related, atrial or atrial pulmonary vein tachycardia, whether it's wide or narrow, it is called supraventricular tachycardia. Any arrhythmia which arises below the level of the His, say from the muscle, that is ventricular tachycardia, or from the Purkinje fibers, that is fascicular VTs, they are all ventricular tachycardia, whether they are narrow or wide. So anything below the level of the His, whatever the structure, it is ventricular tachycardia. And here, when it arises from below the His, A is not the essential part of the circuit. We know that V's will be more than A, but vice versa is not true. For example, you may have supraventricular tachycardia with V's more than A, which I will discuss subsequently, but broadly you should know this definition when you call it a tachycardia as supraventricular tachycardia, or when you call a tachycardia as ventricular tachycardia. Next, let's try to understand what is the basic circuit of your common three supraventricular tachycardias. First common is AV nodal reentrant tachycardia, AVNRT. Second is AVRT, that is accessory pathway mediated tachycardia. Third is atrial tachycardia, or which includes, maybe you can talk about atrial tachyarrhythmias, that is atrial flutter and fibrillation as well. So what happens in AVNRT is your circuit, please remember, in AVNRT, your circuit is within the AV node. So you have your slow and your fast pathway, which is within the AV node. So your circuit is, and this AV node is, where is the AV node sitting? It's within the Cox triangle, which is at the base of the right atrium, and it's a central structure. So because your circuit is within the AV node, and here this is the essential circuit, and activation of atria happens from AV node above, and activation of ventricle happens from AV node through His to ventricle. So please remember, in AVNRT, because circuit is within the AV node, ventricle, or for that matter, atria may not be the essential part of circuit. That's why in AVNRT, you can get 2:1 tachycardia, that is 2:1 AV tachycardia, A is more than V, and very rarely you can get 2:1 VA tachycardia, more V, less A, narrow QRS tachycardia, which is a positive HV tachycardia. Remember this. So in AVNRT, the activation of A happens from this circuit to the node, and activation of V happens from this circuit through the His to the ventricle. So that means A and V are activating almost simultaneously. Activation of V doesn't depend upon the activation of the A. It depends upon this circuit. Because A and V are activating almost simultaneously, or so you get P wave, which is within the QRS, a little bit in the distal part of the QRS, or maybe a little bit before QRS. And the reason why the P waves are so narrow, as I said, because right and the left atria are activating almost simultaneously. That's why P waves are very narrow in AVNRT. So please remember the circuits. So that's why commonly your AVNRT comes in the short RP tachycardia, that is from R to the P wave, because it's a parallel activation. Commonly we say that if RP is less than 70 millisecond, that means chances of AVNRT is very high, although atrial tachycardia also can happen. We will discuss about this. Now let's go to second common tachycardia, that is pathway related tachycardia. So how does pathway related re-entrant tachycardia happens? You have AV node activation, it goes down below the ventricles, and then it comes back and through the pathway, and then atria activates. So it's a big circuit. See this, it's a big circuit. So here A and V are activated in series. This is basic. Please remember this. A and V are activated in series. And secondly, A and V both are essential part of circuit. Because if I block A, then also tachycardia will terminate. And if I block V, then also tachycardia will terminate. So because A and V are essential part of circuit, it takes time. For example, from A via the AV node, it will go to V, then via the accessory pathway, it comes to A. That's why in pathway mediated tachycardia, your RP will be short, but it will not be, or it cannot be less than 70 millisecond, because it will take time for the conduction to go through the AV node to ventricle and come back to atria. And please remember, I think you remember normal HV conduction or normal HV interval is 35 to 55 millisecond. Remember that, correct? And add to that, it has to turn around, go through the pathway and conduct to the atria. So that minimum, that's why usually minimum 70 millisecond is required for the beat to turn around and come up. So even AVRT can be a short RP tachycardia, but not less than 70 millisecond, because A and V are essential part of circuit. So that's why if you have a 2:1 supraventricular narrow QRS tachycardia, your pathway mediated re-entrant tachycardia is ruled out, correct? Because it cannot happen. As I said, if there is a block from A to V, or block A to V, or block from V to A, tachycardia cannot continue. So once you have a 2:1 tachycardia, AVRT is out. Third common tachycardia is atrial tachycardia. So there is a single focus and it is firing. So this focus, whether it's focal mechanism or triggered activity or micro re-entry, or for that matter, atrial flutter, or it's atrial fibrillation, see, it will keep firing. It is not depending, it will not bother whether these beats are going through AV node to ventricle, right? So even in atrial tachycardia, your His and V are not essential part of circuit. This is very simple. So that's why you get atrial tachycardias or AFibs or flutters with variable conductions, or you can have AFib with complete heart block, right? So here also there is V is not essential part of circuit, and you can get variable conduction to the ventricle. So that's why true V to A linking, which we call in electrophysiology, is present only in a AVRT kind of re-entrant tachycardia, because there is a fixed conduction from through the His Purkinje fibers to the ventricle and then through the pathway back. By any chance, because the circuit is very fast, and even if there is a bundle branch block, still it will go through right bundle, cross the conduction and come to ventricle. So even if it becomes wider in AVRT, there is a bundle branch block, still there will be a fixed relation between the via the node between the A and the V, because A and V are essential part of circuit. Remember, this is basics of all three supraventricular tachycardias. So this is what I was talking about. Same thing is depicted in this very beautiful diagram. As you can see, your AV node, re-entrant tachycardia, your circuit is roving here. And then there is from the circuit, slow and the fast pathway, atria is getting activated. And the same time, at the turnaround point, through the His ventricle is getting activated. So that's the reason you can have AVNRT with a block below the His or above the His. 2:1 block you can see. Second, ORT, that is AVRT or orthodromic reentrant tachycardia, or for that matter, even if you have antidromic reentrant tachycardia, that is, what do you mean by antidromic reentrant tachycardia? Antigrade conduction is through pathway, which is wide QRS tachycardia, and retrograde conduction is through the node. But again, here also, both A and V are essential part of circuit. Third is AT, as I said, there's a single focus which is firing and which conduct, few beats will conduct, few beats may not conduct down. So that's why atrial tachycardia can be short RP, long RP, it can be anything depending upon the atrial rate and depending upon how fast is the conduction through the AV node. So that's the same depiction which I'm trying to say, but it is seen in the QRS. That's why in typical AVNRT, you may have a QRS where the P waves are not seen at all because it's so narrow, it merges within this big high frequency R wave. Remember that frequency of the R wave is almost from 30 to 40 hertz, whereas frequency of a normal P wave is just 5 to 10 hertz. So if it's very narrow, low frequency P wave, it can merge within the QRS, or in typical AVNRT, P wave may be in the distal part of the QRS, whereas in accessory pathway mediated tachycardia, it will be little outside, or if you measure from onset of the QRS to the earliest P, it should be more than 70 millisecond. Whereas atypical AVNRTs, which is fast, slow, or slow, it may be a long RP tachycardia, but always remember, in any kind of AVNRT, I'll go back, in any kind of AVNRT, whether it is typical or atypical, because your P waves arise from base of the RV and goes upwards. We call it caudocranial activation of the atria. That's why in your inferior leads 2, 3 AVF, which are inferior leads, P wave has to be negative. By any chance, you have P waves positive in inferior leads, that is 2, 3 and AVF, AVNRT is ruled out. AVNRT cannot happen, because you know that AVNRT circuit is at the lower part of the right atrium. So your atria is activating from down to up. So it is going away from your inferior leads, right? So AVNRT, whatever type, it is not possible if you're inferior, if you're able to see P waves very clearly, and those P waves are positive in 2, 3 AVF, your AVNRT, whatever type, is out. So these are the catheters. These are usually almost 1 meter, 90 centimeter to 1 meter long catheters, and we have multiple electrodes. This is the 4 electrode catheter, which is usually used for His recording. This is a 10 electrode catheter. This is also a 10 electrode catheter with different inter-electrode spacing. This is 2 millimeter, 2 millimeter. This is 2 millimeter, 5 millimeter, which we use for coronary sinus. And this is a deflectable catheter, which is used for radiofrequency ablation. You can see tip of this catheter is bigger than these diagnostic catheters, because this is a deflectable ablation catheter, which we use for ablation. And you have another catheters as well, because this is, for example, this can sit halo catheter across whole of the tricuspid annulus, because if there's atrial flutter, so it covers almost complete circuit of the atrial flutter. You have basket kind of catheter. There are multiple types of catheter, more the number of poles, the quick we can create a map, or quick we can understand the circuit. So we have multiple poles in the catheters. So when we go in the electrophysiology lab, the typical position of the catheters is one catheter is within the coronary sinus. And as per an anatomy, I think you understand that coronary sinus starts from the paraseptal region on the right-hand side, and it is below the mitral valve annulus, and it goes up because here, after the valve, initially it's a coronary sinus, then it becomes a great cardiac vein, and it becomes anterior interventricular vein. And if you push the catheter up, it comes at the base of the left atrial appendage. So because coronary sinus is sitting between atria and the ventricle, this is the catheter which can show both atrial and the ventricular signals simultaneously. This is LO view. That is one. Second, you put one catheter into the right ventricle for pacing the RV. You can see here, this is RO view, LO view. Third, you place, this is the most important catheter in the electrophysiology lab, which defines everything, because to say it's a supraventricular tachycardia or ventricular tachycardia, commonest thing is His positive tachycardia or His negative tachycardia, right? Although if it's a pathway mediated tachycardia, if it's antegradally going through pathway, retrogradely coming through node, it will be negative HV tachycardia. But out of this, maximum all other tachycardias, if it's not pathway mediated, supraventricular tachycardias are positive HV tachycardias. That's why His is very, very important for us. I'll show you how to place His. So His is a structure which is at the apex of the triangle of Koch, and I'll show how it records. The next catheter we use is HRA, that is high right atrium, which is usually placed into the RA appendage because it is stable and sits there. So this is the typical placement of catheters in the electrophysiology lab. So this for us as an electrophysiologist, or maybe basics we should know. So as I said, coronary sinus is just paraseptal where we place a catheter. Then it forms the base of the triangle of Koch. Apex of the triangle of Koch contains His, and this area, one second. So this area shows the compact AV node, and this is your tendon of Todaro, and this is your tricuspid leaflet. I'll show here. So this is how. You can see this is a tricuspid valve. This is your IVC. This is your coronary sinus os. Here you will have a His recording. This is an RO position, RO view. And this is at the lower part. Here usually you get a AV node. So this is here your His. Around this area or around this area, you get a slow pathway. Usually you get a compact AV node or fast pathway in this area. This is your tendon of Todaro. So how do you place the catheters? Or this is the basic recording. Even as an interventional cardiologist, it's better to know about the basic recording. We already discussed this is a CS catheter, RV catheter, His catheter, and HRA catheter. And usually you place at least 3 to 4 surface ECG to understand whether QRS is wide or narrow. For example, V1, V6, 1 and AVF. Usually I also like putting 1 and AVF because it tells you broadly what is the axis, and V1 and V6 usually tells whether it's right bundle, left bundle, narrow or wide QRS. So 2 chest lead, 2 limb leads are good. Then you can see this is an HRA distal signal. This is from HRA, these 2 poles. Then you have HRA proximal signal. This is from the proximal pole. This ablation catheter, usually this ablation catheter looks like they have put across the His. This is ablation proximal, ablation distal. So how do you define the His recording? His recording is, as I said, because it is at the apex of the triangle of Koch, which is at the AV junction. So you will have equal A, equal V, and in between there is an isoelectric signal, which is very high frequency sharp signal, which is His recording. So this recording throughout the procedure is important. You can see here itself, this yellow catheter, this is your His recording. And then your coronary sinus, as I said, records A. Specifically, if I put it from the groin, because it touched towards the roof of the coronary sinus, you'll have a big A signals. Far field, you can see very low frequency signal, far field V signal. Sometimes if I put my coronary sinus through right internal jugular vein, because it goes and sits on the floor, you may have a better ventricular recording here. And this is RV apical. You can see it is recording only V. So how do I know this is V signal? If you draw a straight line here, it is coinciding with the QRS. So this is how, whenever you do baseline, I'll show now baseline measurements, we'll go to that. And please remember, this is for the newcomers. This is an RO view. This is a radio opaque shadow, which is AV canal, because AV canal has a fat. So there you can see a like white shadow, and below you'll have CS os, and here you'll have coronary sinus. This is, His. This is how you realize that I'll go and put my catheter here on the His. This is the placement of a quadripolar, that is 4-pole catheter, to record my His. So as I said, surface ECG, RV, upper right atrial, which is coinciding with the P, that is atrial signal. His signal A, H, V. Coronary sinus signal A and V. Once we place the catheters, we do baseline measurement, that is baseline R to R, how much it is. Then baseline A to H, HV measurements are done on the His catheter. And baseline, what is the width of the His? Normal is 15 to 25 millisecond. So QT interval, you can do all your baseline measurements before you start your basic electrophysiology study, which we do with A pacing and with V pacing, depending upon type of tachycardia, or basic electrophysiology study to induce arrhythmia. So as I said, normally whenever you see a baseline normal sinus rhythm, how does your A starts? Your A starts from sinus node, which is near the HRA signals. then it goes to his, then it goes to anterior, which is anterior, then it goes to proximal coronary sinus, then it will go back down to the distal coronary sinus. And from atria, your his will get activated and your ventricle will get activated. And this is an example how we'll give atrial extras, because if I stress my AV node, if there is a dual AV node physiology, then I may have an AH jump and induce AVNRT. Or if I stress the AV node, if I delay the conduction through the AV node, even if there is an AVRT, this beat may conduct back and I may induce supraventricular tachycardia. So this is an antegrade conduction. Now let's talk about the retrograde conduction, that is V to A conduction. And in the electrophysiology study, when we take the case in the lab, it is important to know V to A conduction. One thing it's important to know, like from A to V or V to A conduction, normally there is no connection across A and V to A except for the his Purkinje system, that is through the his. Only thing is, if a patient has accessory pathway sitting anywhere, that is the only extra connection. So if there is no accessory pathway, if A has to go through V to the V, the only way is through the AV node, his and the ventricle. Same holds true for V. If V has to go to A, it will go from ventricle, muscle to muscle to muscle, enter Purkinje fibers, enter the his, through the AV node, it will go to A. So this normal V to H to A conduction in a normal person is called concentric retrograde CS activation. That means if I have a normal conduction, if I pace from the right ventricular apex, how do I know I'm pacing from right ventricular apex? One, V1 is negative, that is LBBB morphology. Second, can you see AVF is also negative? That means I'm pacing from lower and my beat is going upward. That's why 2-3 AVF will be negative. So normally it will go from here, it will enter AV node, it will go to his first, then from his, it will go to proximal coronary sinus. You can see 910 is a proximal coronary sinus. Then it will go to distal coronary sinus. You can see it will go to distal coronary sinus. And then from his CS, and then at the same time, it will go to HRA. So high right atrium will be getting activated late. This is normal concentric retrograde activation. Presence of this says that there are no free wall pathways. There's a normal concentric activation, although septal pathway or parahis pathway will have also similar kind of activation, but at least your left-sided pathway or your posterior pathway is not there because his is activating before the proximal CS, and HR activation is very late. Second, we all know that AV node has a decremental properties. What do you mean by decremental properties? If I keep bombarding the AV node, keep giving impulses, you know that if I give 100 impulses, there will be AV Wanky back, correct? If AFib happens, fast ventricular rate, if AFib rate is 350 beats per minute, ventricular rate will be 150 beats per minute, because AV node has decremental properties, both antegrade and retrograde. So how do you realize that this patient has only nodal conduction and rule out pathway is when you pace, decrement pace, you can see V to A is 160 and there is a decrement. It became 220 now. There is a retrograde, we call it, the way we have antegrade AH jump, you may have a retrograde V to A jump. So there is a long jump from V to A, but see, activation of atria is same from his to proximal CS to distal CS. So it is still concentric activation, but it is decrement. So chances of having a pathway in this patient is really rare. So you're just trying to show this patient has a nodal pathway, nodal conduction. But you can see now, which we were talking about concentric V to A activation, right? If I pace from V, you are having the conduction from the V pacing. You're having conduction to his, to proximal CS to distal CS. You keep pacing faster, 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 and suddenly you see there is a change here. See this? There is a sudden change here, it's happening. So here it is CS proximal is early, but here it is looking late. And your CS distal has become early, and your his A has become late. Can you see this? It's clearly seen. I put a line here. So here PC has become early. DC has become early, that is distal CS. Proximal C has become late, and then his has become very late. That means initially it was conducting from here. Now it has come back and conducting from DCS to PCS to his. And this happens when this will happen when there is a retrograde left lateral pathway. So this is called eccentric activation of coronary sinus. This says that patient has an accessory pathway and chances of having accessory pathway mediated tachycardia is very high. Other thing I would like to say, this is for people who wants to join fellowship or something or want to understand this running EGM. It's not easy to go through all EGMs. When the EGMs are running, have a habit of seeing only 2 or 3 beats. For example, I can keep watching QRS, it is STIM QRS, and I can see one catheter, and I can appreciate that there is a sudden change from here till here. And then I can go and evaluate all the EGMs, because simultaneously, when you're comparatively new, you cannot evaluate all EGMs and you get all confused. So always see 2 or 3 channels, no need to see all the channels simultaneously. So I think I spoke, this is one of the tachycardia in the electrophysiology lab. Let's walk through the EGMs. Can you see this is a surface ECG and this is a right bundle branch block tachycardia, and you can see number of PVRs are more than number of QRS, right? So it is more A than V with RBBB. Then you should, as I said, always see H to V. You can see H here, you can see V here. So it's a positive HV tachycardia with 2:1 AV conduction. So if it's a positive HV tachycardia, 2:1 AV conduction, which supraventricular tachycardia is ruled out? Your pathway mediated tachycardia is ruled out, right? Because their A and V are essential part of circuit. So chances of this being either atrial tachycardia, or you can have AV and RT with 2:1 conduction. Remember? Now, the way we see this is, so if you get see artifact here, there's a pacing artifact here, there's a pacing artifact here, there's a pacing artifact here. And you're pacing from this channel. And this is a coronary sinus channel. You have A, you have V here. We are pacing from mid part of the coronary sinus. And you can see here, come here up, A, H, V, A to H was 80 millisecond. You again paced A, but there is no HV. But again, immediately you have paced A faster. So there is a block here. Now this A, H, V, and can you see this big delay? Initial A to H was 80 millisecond. Now A to H is 260 millisecond. So there is a big jump, and there is a retrograde. This is an A which is coming back. It's a A on V tachycardia with critical AV delay. Chances of it being AV and RT is very high. But yes, you have to do maneuvers to prove it. I'll discuss about it. But it's a critical AH jump and A on V tachycardia and 2:1 tachycardia where the block is below the His. Anyways, this was an AV and RT with 2:1 tachycardia, and this patient had a block below the His. So usually if you get an AV and RT, you can have 2:1, commonest is 1:1, and 2:1 AV and RT distal to the His is more common than 2:1 AV and RT proximal to the His. This is just a real world data. Now next, basics of supraventricular tachycardia. If you have a supraventricular tachycardia which is running, which is fixed relation between A and V, A and V, A and V. So it's always confusing whether it's AV and RT, whether it's AV RT, or it's atrial tachycardia. So I will not go to details of all the electrophysiology maneuvers we do, but the one important maneuver which we do in the electrophysiology laboratory is overdrive pacing from ventricle. why it is important. For there are supraventricular tachycardia which fixed 1:1 AV relationship. Now, if I do overdrive pacing from ventricle, remember I'll be able to differentiate whether V is essential part of circuit, right? So we always do overdrive ventricular pacing from RV apex. Usually you can do from other sites also. So remember, if I have a atrial tachycardia for that matter with 1:1 conduction from A to V. Now, atrial tachycardia is not bothered whether I'm going to ventricle or not. If I start pacing from ventricle and if I start pacing faster than my atrial tachycardia, I may suppress this atrial tachycardia, right? So V2A, V2A, V2A conduction will happen. VA will happen and I stop pacing when I post VOP is called post ventricular overdrive pacing response VC. So V2A will happen and I stop pacing. If it's an atrial tachycardia, again new rhythm will come. Again A to V will come. So the last pace beat when I stop, we see a response which we call it V pacing, VA, AV response. It says it's an atrial tachycardia. It cannot be AVNRT or it cannot be AVRT. I'll go to next. If it's an AVRT, and we have already discussed in regular pathway relay, that is AVRT, A and V are essential part of circuit. If I start pacing ventricle during tachycardia and stop, your last beat will be V, A, and V tachycardia. So VAV tachycardia, and because A and V essential part of circuit, once I stop pacing, because I'm pacing within the circuit, after stopping pacing, although it's a VAV response, but from post-pacing interval, I'll show an example, will be very short because I'm pacing almost within the circuit, which is usually less than 85 millisecond. Whereas in AVNRT, because your circuit is in the node and V is not essential part of circuit, if I pace from V, remember AVNRT is A on V tachycardia. If I pace from V, it has go from down to through the bundle to his to A. So this is longer activation. It is a series activation. So again, it will have a V AV response, but post-pacing interval will be long because V is not an essential part of circuit. I'll show case examples. This is a classical case of AVNRT which is induced in the lab. You can see surface ECG, His recording, CS recording. You are pacing from A, H, V, A, H jump. After that, A on V tachycardia is induced. You can see it's an A on V tachycardia. This is V, this is V, this is V, and this is A, his CSA. So it's an A on V tachycardia. This is just, I wanted to show an example because few supraventricular tachycardia may be really troublesome for the patient because they are hemodynamically unstable. So some supraventricular tachycardia are really hemodynamically unstable and trouble the patient. So it's you should not treat all AVNRTs as benign tachycardias. So anyways, so this patient is running tachycardia. As I said, you start doing ventricular overdrive pacing, which is usually 30 millisecond faster than the tachycardia. So tachycardia is running at a rate of 310 millisecond. You are pacing at 280 millisecond, and then you keep pacing. You have entered the circuit, and when you stop pacing, as I said, again measure it. You have entrained the tachycardia because you have VA relation. So once you stop pacing, you have a VA his V relation. So when you have a VAV tachycardia, atrial tachycardia is out, possibility of AVNRT and AVRT is there. Although we have already discussed when it is an A on V tachycardia, accessory pathway mediated tachycardia possibility is very, very far. I'll not go to complicated nodofascicular pathways and all, but extranodal regular pathways are out. But still, here you can see post-pacing interval is very long. This is 300, 180, it is 180 millisecond. Anyways, we correct it, but still it is very long. So this is AVNRT. So as I said in AV and RT, you keep pacing ventricle because it takes long time to enter the circuit and comes back. Your post VOP response will be long in AV and RT. Coming down to another example of tachycardia, there's some tachycardia going on, narrow QRS, regular tachycardia, and it's comparatively a long RP tachycardia. You can see his recording AHV. This is HRA recording, and this is a CS recording, and his recording is earliest. His is earlier than HRA here. So we don't know what tachycardia is this. So what we will do, it's a fixed relation between A and V. So we will be doing ventricular overdrive pacing in this. This is just a surface ECG of this fast, regular, narrowed QRS tachycardia. Tachycardia cycle length is 300. Cycle length means, usually remember in electrophysiology laboratory, we don't talk in terms of beats per minute. We talk in terms of millisecond. How much is the millisecond rate? So this is 310 millisecond. You pace 30 millisecond faster than the tachycardia cycle length. You're pacing from RV apex. You stop pacing and it has entrained the tachycardia. How do I know I've entrained the tachycardia? V to V is 280. A to A is also 280. That means V has pulled in or entered the circuit, and it's a V A V tachycardia. Remember? V A V tachycardia. So what does it mean? So that means I've paced, stopped tachycardia, restarted with the new way. So that means it's an atrial tachycardia. So it's an atrial tachycardia which we have to map. And this is the circuit which I spoke to you. This is an atrial tachycardia running. You overdrive, suppress, you stop pacing. VA will happen and you stop, and again A to V will happen. So this is an atrial tachycardia. Anyways, it was mapped in the non-coronary cusp. This is your non-coronary cusp, which is, this is your his catheter, and you ablate and your tachycardia gets terminated. And once tachycardia gets terminated, you pace very fast, and to show that again tachycardia is not getting induced, to make it sure that it's a successful ablation. So this is another case example. Shall we stop here, or you want me to show more cases, or we can have question and answer session here? I can stop here. Sharda ma'am, Mukund, Anupam ma'am.
Yeah, I think I think you have already spoken about the basics of AV and RT and basic
correct.
understanding. If you want, maybe you can show something about how to recognize VTs and
Yes, I have. I'll show.
yeah.
We'll go to VT. We'll go to
Yeah.
VT. That's a good idea. So I'll just show a case of 1 or 2 cases of VT, ma'am.
Yeah.
So this is a case where there is an intracardiac recording. Again, we will go. This is a surface ECG V1 AVF lead 1. This map distal is in right ventricle from where you are pacing, and because there is a pacing artifact here, and it is pacing from RV apex left bundle AVF negative. His is in his, but you're not able to appreciate because QRS is starting before this. This is a coronary sinus recording. This is A, this is V. So you have paced from ventricle and stopped, and you can see here even in Holter or here, there is a wide QRS tachycardia induced. This is a wide QRS tachycardia. Where can you see? These are V's, and this big signals are A's. So one, it is V's more than A. So whenever we say V more than A, chances of VT is very, very high. It's a VT, that is one. Second, it's a negative HV tachycardia, right? We discussed anything which is negative HV tachycardia, which is V's more than A, is a ventricular tachycardia. This is an example of ventricular tachycardia induced in the electrophysiology lab. This I'll skip, but I'll show one more interesting case before I stop. These I'll skip. This is a nice case to discuss. This is not intracardiac EGM, it just surface ECG. This was a 4-month girl, accidental detection of tachycardia, no symptom. This is the only rhythm. Patient had some upper respiratory tract infection, rate was fast, asked to do ECG, sent to us. Now let's walk through this ECG. One, it is a right bundle branch block tachycardia, right? Second, it's not that wide or that narrow tachycardia. Third, what we see usually in the white QRS tachycardia, because this ECG was diagnosed as just a supraventricular tachycardia. I don't remember, whatever. So it was diagnosed as a supraventricular tachycardia. Now a child who's 4 months, we all know that RBBB can happen in them, right? That is one. Second, but same thing in a child, normal child till 1 year of age, they may have a rightward axis. Here, what is glaring? R is smaller, S is bigger. Deep S. R is smaller, S is bigger. This is right, leftward axis. So it's a right bundle, leftward axis tachycardia. Anything which is more glaring here, it's very nice. It's very specific diagnosis is there. Can you see this P wave? This is the P wave. This is the P wave. This is the P wave. This is not the P wave. This blip is the part of QRS. This blip is the part of Q. This is the P wave. This is the P wave. And you can see that QRSs are more than the P wave. One, it is right. It's a structurally normal heart. So right bundle, left axis tachycardia, that is one. We always talk whenever there is a opposite axis, if it's a baseline structurally normal heart, chances of VT is very high. Second, V's are more than A. There is a clear AV dissociation. So this is a VT, and what VT it is? It is fascicular VT going on. And I've just highlighted was for the understanding the VA dissociation. And this is after termination. It's very nice. Can you see first R, rabbit ear has become smaller than the second. This is typical RBBB. That is one. And can you see now this R has become prominent. This R has become prominent. This R has become prominent. They may have all the T wave inversion for first few years, pediatric age group. But again, I'll again go back just to teach. Can you see this negative? This first rabbit ear is bigger and AV dissociation. So this is a ventricular. So if it's a narrow QRS tachycardia, if it's an RBBB tachycardia, if a person is, especially child, is hemodynamically stable, it doesn't rule out ventricular tachycardia. That is one. Second, if it's a supraventricular tachycardia, it's not true that all supraventricular tachycardias are hemodynamically stable. I've already shown a case example. I think I'll stop here, ma'am.
Yeah, Daljit, excellent presentation and very exhaustive, very nice recap of SVPs and
to a certain extent, we should.
yeah, just a
Just
few
a few points on the ECG, perhaps we can focus on the ECGs a little bit more to take our students from
ECGs,
EP lab. So the first ECG that you shown and you dissected out very well. I thought, can you just show that ECG again?
Which one, ma'am? 1 second. I'll start sharing.
Very first one, AVNRT that you were discussing.
This one, ma'am.
Yeah.
So,
So like, no, just let's focus on the ECG alone. You can see, I don't know if the students can see in V2, another little bit of QRS alternance. Like you can see one QRS is slightly bigger than the other and so on. Maybe it's not like so very consistent. This is one which is told
quite often
that
that
QRS alternance points to pathway mediated tachycardias. But I just wanted the students to know that it's more true when the rates are a bit more lesser. At a higher rate, even AVNRT can show subtle QRS alternance like it showed here.
So what is high and what is low is really not like so categorical, but anything more than 180 to 200, you would think is fast. And at that rate, bets are off whether it's AVNRT or EVR. Then even in V3, you can see the terminal is which indicates short architect value. And so in general, again, coming back to ECG, can you hear me?
Yes, ma'am,
Yes,
you're
we can
audible,
hear you.
ma'am. You're audible.
No, so usually there is something called like more than age. So all Fs like age more than 40 or female and frog sign if you have. Chances are that a narrow QRS regular tachy is more like AVNRT. So again, as Daljit explained so well, when you have when P and QRS are lined up as an AVNRT, they're nearly simultaneous. It's a simultaneous VA activation there because the junction is getting activated first. The tachy is going on in the junction, and the A and B are like bystanders. They're getting activated nearly simultaneously. So there is frog sign or cannon waves which occur almost regularly. And because AVNRT has certain regeneration of the pathway around the coronary sinus. And in fact, one of the echo hallmarks of AVNRT is a dilated coronary sinus os. So when you have that, so a female and 40 years and a frog sign, these three put together, the bets are more like if all three are positive, then it's likely to be an AV nodal reentry than other tachycardias. So while narrow, finally, again, for a student, all of them are treated in the same way. An SVT or paroxysmal supraventricular tachycardia or a narrow QRS regular tachycardia, they're all treated only in one way, and that's first with vagal maneuvers, then adenosine, then AV nodal blockers, either beta blockers or calcium blockers. So basics remaining basic in an ER, you don't decipher and you don't get confused whether it's AVNRT, AVRT. So like this is very nice to know, and knowledge is always power. Always have a DFib backup whenever you're intervening in any tachycardias, except perhaps for vagal maneuvers. Anytime that you're trying drugs, including short-acting adenosine, always have a DFib backup because there's always that minor chance of having AFib or fast VPs occurring due to our intervention. Yeah, Dr. Mukund, because like Daljit is like so exhaustive. I was wondering maybe an ECG would be initial point of interest for our students.
Yeah, Diljit, this was a very nice, wonderful talk. So exhaustive, actually. I just want to introduce. Can we just discuss about role of EP study in bradyarrhythmias? We have not touched upon that probably. Whether syncope or bradyarrhythmia values, what's the role of EP study? What we looked while we do the study.
Yeah, it makes sense.
When do we prefer a
good point.
halter
It's-
versus
yeah,
when do we
Yeah,
do
it's a
EP
good
study?
point. I think I should have included some Brady studies because it's clinically number of doing the Brady studies are less as compared to for the techie studies. So one is commonest is if we are confused whether it's an AH block or HV block nodal. I'll not talk about SNRT and all because SNRT we need to discuss in detail. But more than that, more simpler is when you want to see whether it's an AH block or HV block in the lab. So normal intervals, we see AH and HV. Normal HV interval is 35 to 55 millisecond. And if the baseline interval is itself is more than 100 millisecond, there is a high chance even if baseline QRS looks narrow, it can happen. If it is wider, we don't have confusion. But if it is narrow, we are more confused because specifically if HV is long and baseline QRS is narrow, that means conduction through both the right and left bundle is equally slowed down, and that's why you have a narrow QRS. So baseline HV of 100 millisecond, although normal is 35 to 55, that means high-grade AV block chances are high. That is one. Second, when you do decrement pacing and you have an HV block at baseline without any drugs, if you are trying to search for the Brady study, that means it is an high-grade AV block. That is second. Third, if you have an HV block with bundle branch block, again, it is a chances of high-grade AV block is there. That is third. Then SNRT, many people question about it, but we can do it to see for sick sinus syndrome. In SNRT, it's better not to give any drugs when you take the patient in the lab. Pace from high right atrium, that is near the sinus node, not from the coronary sinus. Usually we pace at 3 different cycle lengths, which is at least 100 to 150 millisecond different. You can start from, for example, patient's own heart rate is maybe 60 beats per minute or 1000. Then you can start like 200 millisecond faster and keep coming down. And we calculate CSNRT out of that. I think I should have some EGMs from that. You pace and stop and measure the pacing interval from his second HRA, which is coming, and normal corrected sinus node re-entry time is, it should be more than 550 millisecond, corrected we call it, and uncorrected it's more than 1500 millisecond, we call it abnormal. I'm sorry, more than 550 millisecond corrected sinus node re-entry time is considered as abnormal, and uncorrected more than 1500 millisecond. That is one. Second, sometimes you get secondary pauses. I pace from HRA, stop, my sinus node re-entrant time is normal, but after 2-3 beats, there are long pauses. Like we see sinus pauses. If it is more than 5 seconds, we say that sinus node is disease. But there is a caveat to this. Always remember, sinus node disease doesn't mean that patient needs a pacemaker. You have realized that there is a sinus node disease is present, but depending upon the patient's symptoms, clinical detail, you put a pacemaker. All patients of sinus node disease may not need a device, but you can put in the thing that, yeah, it's a disease sinus node. I'll be cautious of giving antiarrhythmic drugs and all those things. And this can progress in future, or you can search for the secondary causes of it. I think this is, yeah, is there anything we can add? Mukud, Sharda ma'am?
You summarized it very well, Diljit. Yeah, probably unexplained syncope is one thing where we still consider EP study. All other aspects probably are covered. Thank you. That was very nice.
Thank you. Sharda ma'am, anything we need to add to this? I think you're muted, ma'am.
Dr. Daljit, can you stop sharing your screen
Yes,
so that
sure,
we
sure,
can
sure.
see each other again?
Yes, ma'am. Yes, ma'am.
So like we can just go with the chronotropic competence on a treadmill to see how things are. You can see, because we're talking to non-electrophysiologists, so perhaps for them it's easier to start off from there. When they don't achieve the usual 85% target heart rate, or there are some ectopics, complex ectopy going on, you know that things are not good. And one of the easiest way of identifying an intrahesian disease where the QRS looks narrow, but you're not sure whether it's a high-grade AV block, especially when there's symptoms, is that when you put them on treadmill, you unmask the intrahesian or the intrahesian conduction system disease. And so the various things that you can do without getting actually into EP lab. And perhaps the more practical question would be whether you want to give a dual chamber or a single chamber when resources are limited. You're thinking it's 6 sinus now. Do I need to give a dual chamber immediately, or what's the chance of the patient having a subtle AV nodal disease, which is going to create problems when I give? So perhaps at that point, you can do an e-pacing with a temporary wire. And if it conducts 1-to-1 at a pacing rate of 150, it's usually reasonable to say that that particular Avinol is robust enough to sustain for the next 10 years or so, when the patient may come for a battery change, and then you can think of an upgrade to a dual chamber if required. Because there is a certain progression of avinodal disease in a patient with sinus. So there are many aspects. Perhaps it's not fair to ask Daljit to cover all the Brady and Kathy, and she did her best to cover from more of an EP perspective, because she's so much into EP. I hope students could catch something which is useful to them in day-to-day practice, and then get them interested into EP to unravel this puzzles a little bit more. I think it's a good job and well. Any questions from the audience?
I think one question was that child with ventricular tachycardia actually didn't revert with anything. So one point, if we want to tell children, never use IV calcium channel blocker, because asystole chances are very high. So because child was hemodynamically stable, oral beta blocker, oral calcium channel blockers were tried. After 15-20 days, child was called again. It was not reverting. All the drugs were tried actually. After that, child was developing LV dysfunction slowly. So ultimately, we had to cardiovert. After cardioversion, the child reverted to sinus rhythm. And after that, surprisingly, there was no recurrence. So for 2-3 months, I gave oral calcium channel blocker to the child. And after that, I tapered it off and stopped. It's a very old ECG, actually, many years back. But it never recurred for that child. It was related to possibly some viral infection or something. But yes, only one point if we want to tell. We tried overdrive atrial pacing as well in the child. In the children, you can do because 4-month child, you can put a TPI through the orally, sedate orally, and you can pace from the left atrium, which is just in front of your esophagus. Atrial overdrive was attempted, it didn't revert, so we cardioverted child.
So usually, Dr. Daljit, how much, what is the weight-wise dose of when you use cardioversion? Because rarely we also do come across
1
babies.
unit per kg, ma'am. One
Yeah,
unit, one
yeah,
joule
same,
per,
yeah.
sorry.
1 joule per kg.
Per
We also
kg,
do that,
yes.
but if it doesn't respond, we go to 2 joules. So what is the maximum that we can use?
I don't know, ma'am. I'm sorry. If someone else can answer,
Yeah,
seriously.
because we also came across a small neonate actually who was having continuous tachycardia, structurally normal heart, but then we tried drugs, but he was not responding. Then he started developing LV dysfunction because of high rates, so we had to cardiovert. But fortunately, the baby responded. But then after that, we sent him to a pediatric electrophysiologist because we didn't know what to do next. And moreover, I think it is not advisable to give amiodarone in these babies because if they develop hypothyroidism, it is associated with cretinism-related mental retardation also. So my knowledge is very basic about it. So would you like to have some comments on that?
Ma'am, one thing is, I have never seen a child where tachycardia is not terminating. Yes, it terminates and restarts. It's very important. When
Yeah,
we
that's what I meant.
cardiovert, yes, when we cardiovert, it's also very important to see the strip. One, it failed to terminate. Other, it terminated and restarted. First thing is it failed to terminate, then you can increment, you can increase little higher joule, but as you said, maybe instead of 1-2 joule per kg. But if it is terminating and restarting, we should never cardiovert again. We should use another modalities. That is, we can do overdrive pacing, which is much safer. That is second. Third, yes, we can change drugs. If it is still not working, yes, there are few kids, it's very rare. I'm sure Shada ma'am also would have seen, and we have also seen it's really rare. We take them to the lab for ablation, but for the pediatric, it is rare. The only one child I've seen which never worked, child has a jet. Surprisingly, it was a structurally normal heart jet. It never reverted. So we had to ablate, and when we ablated, obviously child developed. We initially tried ablating lower, it didn't work. Then we had to put temporary, an epicardial pacemaker was given in the child because child developed EF of over the months, 15% EF was going into heart failure and all. But after that, it became normal. But yes, these are very, very rare kind of things. So the thing is, if it's reverting and restarting, we should not give multiple shocks. We should try another modalities.
Right. Thank you. It was really, really very interesting talk. And when you were talking, I was just wondering that you are explaining arrhythmias and basics so clearly, so lucidly. So why don't you write a book for the like basics of electrophysiology? Because the books usually are very complex, and especially for residents. So you explained very nicely, and Sharda, you also discussed the many very important points. So if anybody else has any question or comments, please
There's one
welcome.
question in the chat box regarding PGRT and JET, which probably Diljit can address, I think. And regarding pediatric cardioversion, that as you rightly told, madam, that the maximum joules is 2 joules per kilogram. If that doesn't work, actually we can try for, especially for atrial arrhythmias, anteroposterior playing cardioversion, where we put one pad in the interscapular region. Internal cardioversion also is described, but to the best of my knowledge, not available in our country.
Thank
So
you so much.
PGRT is initially, thank you. PGRT is initially was, the terminology was used as a permanent junctional reciprocating tachycardia, which is not true actually, because initially we used to think that it cannot be cured. But PGRT is actually paroxysmal or paroxysmal junctional reciprocating tachycardia. Commonest reason or the cause is slowly conducting accessory pathway, not decrement, but slowly conducting accessory pathway. If the accessory pathway is conducting very slowly, uh, it behaves like your excitable gap is very huge. So that's the reason child will be in incessant tachycardia. It is difficult to treat. So usually ablation is the cure for these kind of tachycardia. That is PGRT because it is accessory pathway. Whereas JET is completely different. JET is junctional ectopic tachycardia, which arises from the different parts of the His. So it is arising from the Purkinje fiber or from the His, which is automatic tachycardia. Whereas PGRT is a re-entrant tachycardia. And most common cause of JET is you will see in the newborns or in children who's having either some surgery done, corrective surgeries done, having electrolyte imbalances. They may be having some viral fever and all. And usually once you correct the underlying cause, it gets cured. So what I spoke about junctional ectopic tachycardia in a structurally normal heart is really, really very rare. But usually you'll find a cause. You will see people who are handling the pediatric ward where the major surgeries are done, major corrective surgeries are done, TOF repair surgery or Glenn or whatever. So they will have lot of jets. And usually they're on NORADs and all, or they'll have electrolyte imbalance. But once you treat the underlying cause, they usually it reverts.
Also for the students, I thought what Daljit mentioned about hemodynamically poorly tolerated tachycardias. It's true that SVTs are poorly tolerated in stiff ventricles, like hypertrophied ventricles, elderly people, hypertensive patients, aortic stenosis. Whatever makes the ventricle more stiff, atrial arrhythmias or SVTs are very poorly tolerated, and you can see the blood pressures zooming down with the onset of tachy. So again, the caveat that hemodynamically, if it's tolerated, it's more like an SVT, and it's poorly tolerated. SVT is not always true. So again, for students to keep in mind, there are always exceptions to the usual rule. I think if there are no questions from participants, there are some 30 odd participants. If they put up something in the chat box.
I think we have taken care of the questions, ma'am. That's what I am understanding.
I think it's time to part. Very complex job done very beautifully, Daljit. Once more, congrats for you.
Thank you, thank you, thank you. Thank you for the opportunity.
Thank you, everybody, and Jyotsna madam and Anupam. Daljit, always a pleasure to listen to her.
Thank you, ma'am.
Nice to know.
Thank you. Special thanks to Sharada, my dear friend, who was, despite her health problems, she joined and made the session very interesting. And Dr. Daljit, as always, you were really awesome in your talk. And Dr. Prabhu, thank you so much for raising some untouched or forgotten issues like complete heart block in EGMs. Thank you very much. And if Dr. Soumya is there, can we ask her to?
You can conclude. I'm there.
Okay, so we conclude the session. Thank you again. Good evening to everyone.
Thank you.
Thank you. Thank you all. Bye.